Emergency Medical Treatment and Active Labor Act, Wikipedia audio. The Emergency Medical Treatment and Active Labor Act is an act of the United States Congress, passed in 1986 as part of the Consolidated Omnibus Budget Reconciliation Act. It requires hospital emergency departments that accept payments from Medicare to provide an appropriate medical screening examination to anyone seeking treatment for a medical condition, regardless of citizenship, legal status, or ability to pay. Participating hospitals may not transfer or discharge patients needing emergency treatment except with the informed consent or stabilization of the patient or when their condition requires transfer to a hospital better equipped to administer the treatment. EMTALA applies to participating hospitals. The statute defines participating hospitals as those that accept payment from the Department of Health and Human Services, Centers for Medicare and Medicaid Services under the Medicare program. Because there are very few hospitals that do not accept Medicare, the law applies to nearly all hospitals. The combined payments of Medicare and Medicaid, $602 billion in 2004, or roughly 44% of all medical expenditures in the U.S., make not participating in EMTALA impractical for nearly all hospitals. EMTALA's provisions apply to all patients, not just to Medicare patients. The cost of emergency care required by EMTALA is not directly covered by the federal government. Because of this, the law has been criticized by some as an unfunded mandate. Uncompensated care represents 6% of total hospital costs. Mandated and non-mandated care. Congress passed EMTALA to eliminate the practice of patient dumping, i.e., refusal to treat people because of inability to pay or insufficient insurance, or transferring or discharging emergency patients on the basis of high anticipated diagnosis and treatment costs. The law applies when an individual seeks treatment for a medical condition or a request is made on the individual's behalf for examination or treatment for that medical condition. The U.S. government defines an emergency department as a specially equipped and staffed area of the hospital used a significant portion of the time for initial evaluation and treatment of outpatients for emergency medical conditions. This means, for example, that outpatient clinics not equipped to handle medical emergencies are not obligated under EMTALA and can simply refer patients to a nearby emergency department for care. A normal pregnancy delivery. In a case reviewed by courts, EMTALA did not cover the hospital stay. An emergency medical condition is defined as a condition manifesting itself by acute symptoms of sufficient severity such that the absence of immediate medical attention could reasonably be expected to result in placing the individual's health in serious jeopardy, serious impairment to bodily functions, or serious dysfunction of bodily organs. For example, a pregnant woman with an emergency condition must be treated until delivery is complete unless a transfer under the statute is appropriate. Patients treated under EMTALA may not be able to pay or have insurance or other programs pay for the associated costs but are legally responsible for any costs incurred as a result of their care under civil law. Not all medical conditions qualify for uncompensated mandated services imposed by EMTALA, which is contrary to the misperception that many individuals assume that if they are ill, they will be treated, regardless of their ability to pay. The sole purpose for the EMTALA mandated MSE is to require emergency department to make a determination whether an emergency medical condition does or does not exist, using their normal assessment and diagnostic protocols. Since the MSE is a mandated EMTALA service, health insurers are required to cover benefits for their subscribers. They are also required to cover EMTALA-mandated services necessary to stabilize individuals determined to have an EMC. EMTALA intentionally omitted any requirement for hospitals to provide uncompensated stabilizing treatment for individuals with medical conditions determined not to be an EMC. Therefore, such individuals are not eligible for further uncompensated examination and treatment beyond the MSE. A patient is defined as stable, therefore ending a hospital's EMTALA obligations, if the patient is conscious, alert, and oriented, the cause of all symptoms reported by the patient or representative, and all potentially life-threatening, limb-threatening, or organ-threatening symptoms discovered by hospital staff, has been ascertained to the best of the hospital's ability. Any conditions that are immediately life-threatening, limb-threatening, or organ-threatening have been treated to the best of the hospital's ability to ensure the patient does not need further inpatient care. The patient is able to care for himself or herself, with or without special equipment, which if needed, must be provided. The required abilities are breathing, feeding, mobility, dressing, personal hygiene, toileting, medicating, communication. Another competent person is available and able to meet the patient's needs following discharge. A significant portion of emergency room visits are considered not to be EMCs as defined by EMTALA. The medical profession refers to these cases as non-emergent. Regardless, this impressive term is not recognized by the law as a condition defined by the EMTALA statute. A term more relevant for compliance with EMTALA is non-emergency medical condition. If this non-emergent term is used in the context of EMTALA, it needs to be defined as medical conditions that fail to pass the criteria for determination of being a true EMC as defined by EMTALA statute. If a patient is already in the hospital for another reason and develops an emergency condition, EMTALA similarly does not apply. Non-covered medical conditions. Hospitals have 3 obligations under EMTALA. Hospitals have no obligation under EMTALA to provide uncompensated services beyond the screening exam unless the exam determines the patients have emergency medical conditions. Since its original passage, Congress has passed several amendments to this act. Additionally, state and local laws in some places have imposed additional requirements on hospitals. These amendments include the following. The most significant effect is that, regardless of insurance status, participating hospitals are prohibited from denying a MSE to individuals seeking treatment for a medical condition. Currently, EMTALA only requires that hospitals stabilize the EMC. According to some analyses of the U.S. healthcare social safety net, EMTALA is an incomplete and strained program. According to the Centers for Medicare and Medicaid Services, 55% of U.S. emergency care now goes uncompensated. When medical bills go unpaid, healthcare providers must either shift the costs onto those who can pay or go uncompensated. In the first decade of EMTALA, such cost shifting amounted to a hidden tax levied by providers. For example, it has been estimated that this cost shifting amounted to $455 per individual or $1,186 per family in California each year. However, because of the recent influence of managed care and other cost control initiatives by insurance companies, hospitals are less able to shift costs, and end up writing off more in uncompensated care. The amount of uncompensated care delivered by non-federal community hospitals grew from $6.1 billion in 1983 to $40.7 billion in 2004, according to a 2004 report from the Kaiser Commission on Medicaid and the Uninsured, but it is unclear what percentage of this was emergency care and therefore attributable to EMTALA. Financial pressures on hospitals in the 20 years since EMTALA's passage have caused them to consolidate and close facilities, contributing to emergency room overcrowding. According to the Institute of Medicine, between 1993 and 2003, emergency room visits in the U.S. grew by 26%, while in the same period, the number of emergency departments declined by 425. Ambulances are frequently diverted from overcrowded emergency departments to other hospitals that may be farther away. In 2003, ambulances were diverted over 500,000 times, not necessarily due to patients' inability to pay. Examples of conditions not considered emergencies by courts or hospitals. Hospital obligations. Amendments. Effects. Improved health services for uninsured. Cost pressures on hospitals. Notes and references.